Hello and welcome. My name is Dr. Jack West, and I'm a medical oncologist and the founder and CEO of GRACE, the global resource for advancing cancer education. This is part of a series of podcasts covering challenging clinical cases in lung cancer that don't have a clear, correct answer for the best treatment based on the evidence, and they therefore require our best judgment as experts consider the options and the merits of one treatment over another. The same series of cases was discussed with multiple experts in the field of lung cancer from several different institutions to provide a better sense of where there is consensus and where there is still a wide range of treatment styles that might all be considered appropriate. Each podcast starts with a brief thumbnail of a case presentation and then discussion from a live program done with Dr. Robert Doble, Assistant Professor of Medical Oncology at the University of Colorado Medical Center in Denver, Colorado, and Dr. Jyothi Patel, Associate Professor of Medical Oncology at the Feinberg School of Medicine at Northwestern University in Chicago, Illinois. The discussions will then continue with commentary by several other clinical experts, including Dr. Suresh Ramalingam from the Winship Cancer Center, Emory University in Atlanta, Georgia, Dr. Jonathan Goldman from Premier Oncology in Santa Monica, California, Dr. Julie Brahmer from Sidney Kimmel Cancer Center at Johns Hopkins University in Baltimore, Maryland, Dr. Heather Wakelee from Stanford University Cancer Center in Palo Alto, California, and Dr. Karen Reckamp from the City of Hope Cancer Center in Duarte, California.
Next patient is a 62-year-old man with a moderately differentiated squamous cell non-small cell lung cancer just under 5 centimeters in the right lower lobe. He has modestly enlarged mediastinal nodes at 4R and also in station 7 that measure 1.2 and 1.7 centimeters on the CT, and then he also had a PET scan that shows uptake in the range of an SUV of 5. He ultimately sees a surgeon and has a mediastinoscopy that confirms involvement of disease in those 2 stations, but the rest of his workup shows no evidence of distant disease. At this point, it is multi-station, but it's not bulky, and the question is, at your institutions or in your own recommendations, do you have a preferred approach for this situation of multi-station stage 3A N2 non-small cell lung cancer in terms of surgery or non-surgical approach? And if it is a preoperative approach, what do you tend to favor for a preoperative strategy? I'll start with Bob if you can.
Sure. So, stage 3 lung cancer is one of the most interesting, gives us the most room to practice the art of medicine. I've worked at 2 institutions, and typically for anything over single-station disease, we've favored chemoradiation over surgery, although you bring up an interesting point that this is non-bulky disease. For single-station N2 disease, if this is PET-avid disease, we might even treat with induction chemotherapy first and do a mediastinoscopy after induction chemotherapy to see if there's been clearance. If not, then move on to more definitive chemoradiation. I think with stage 3A disease, the survival with either chemoradiation or surgery and other modalities is often very similar. The 5-year survival rates typically hover around 20%, and that unfortunately most of our patients fail more distantly because of our staging techniques, fail to pick up microscopic metastatic disease. So I think both are very reasonable, but typically for multi-station disease, I think we would favor chemoradiation in this setting.
If you do a surgical approach, do you favor chemotherapy alone or a shorter course of chemo and radiation then leading into planned surgery?
I've been at institutions where we've done it both ways. I think the outcomes are very similar. So typically when I've done chemoradiation, we go to smaller dose, typically 45 gray. Again, for multi-station, I've typically shied away from planning a surgical approach. In that case, we go to more definitive doses of radiation.
Thanks. So, Jyothi, let me turn to you. How would you typically approach a patient with stage 3A N2 disease that is more than one station but not extremely bulky?
So generally I would agree with Bob's comments in that we would treat this patient with chemotherapy and radiation. I reserve a chemotherapy alone strategy for patients who either have microscopic disease or have one station of confirmed disease by mediastinoscopy. And this is a subcarinal node and an R4 node. There's some intervening nodes that you can't really get a good handle on with just mediastinoscopy oftentimes. So we have 2 confirmed areas. We would, at our institution, generally treat this patient with full dose cisplatin etoposide, and our radiation, we generally go to 60 or 66 gray. This is definitely a gentleman in which we would consider resection. And for the following reason. So this is a 62-year-old man, presumably, like most of your patients, Jack, in Seattle, these are very healthy people who are active and feeling well. So if he doesn't really have problems with COPD or other comorbidities, if this was a well man, our approach would be to attempt trimodality therapy. The patients in whom we will not do surgery are patients who would require a pneumonectomy, for example, after chemotherapy and radiation, because we know there's increased mortality. The intergroup study, Kathy Albane's study, looked at giving abbreviated radiation to 45 gray and then taking patients on to surgery or completing chemotherapy and radiation. My feeling is that break could be detrimental to patients. So sort of a reevaluation at 45 gray gives cancer cells a chance to repopulate, and there's not that much more information you get at that point. So we generally go full course, and our surgeons feel very comfortable doing it. If they are going to operate, though, they want to do so within 6 weeks of completion of chemoradiation. And these patients are followed very closely. We all often do a CT scan just to make sure that we're not running into toxicity issues in the 5th or 6th week of radiation to make sure that we're all on the same page with what's happening to the patient. But we definitely offer a lobectomy to patients with multi-station disease. Again, these 1.2 and 1.7 are small nodes. I think traditionally we call bulky adenopathy, things that are over 3 centimeters. So these are small nodes in a well gentleman. If he flies through full chemoradiation, then we'd consider resection. The intergroup study, again, most of the people that had problems were those that had to have bigger surgeries for clearance.
So the option of doing chemoradiation to really a full dose followed by surgery, tolerability has been okay, you found? And let me ask also, do your surgeons do a mediastinoscopy after this as any kind of decision strategy of whether to proceed with the resection or not?
They don't. If the patient has had a preoperative mediastinoscopy, we would go by imaging alone. But they would probably sample the nodes, so the approach would be with that to look at the mediastinal nodes and then consider the lobectomy. If there was gross positive disease in those nodes, then they would probably stop. Often, these patients, especially with our 4 nodes and maybe with subcarinal nodes, we will have sampled endoscopically, either with bronchoscopy or EGD, and so we'll have the staging before, and then we'll give chemoradiation and save the mediastinoscopy for before the surgery, but we won't do a repeat mediastinoscopy. Our feeling is generally that truly doing good staging after chemoradiation with EBUS is difficult.
Dr. Suresh Ramalingam from the Winship Cancer Center, Emory University in Atlanta, Georgia.
So this patient having non-bulky multi-station disease tells us clearly that he is at high risk for recurrent disease. This is stage 3A disease. This is something that we often discuss in the tumor boards, and there are many opinions. My own view is the more the number of stations that are involved, the less likely that we are going to help them with surgery. Using a definitive chemoradiation approach would be my choice. But I also know that another acceptable approach for managing this patient would be to give chemotherapy and then do surgery after they get an induction chemotherapy. I'm not sure if I would use all 3 modalities in this patient, that is, giving chemoradiation and then taking this patient to surgery. So if one were to do an induction chemotherapy approach, I think it will be important to assess what kind of response this person has had after the induction therapy before making a decision about further surgery. So I would approach this with definitive chemo-RT if we know that this patient clearly has multi-station N2 disease.
Dr. Jonathan Goldman from Premier Oncology in Santa Monica, California.
This is a 3A disease, but multi-station 3A. I think you'd have to be very careful with a patient like this not to put him through excess toxicity without a real clear evidence of benefit. I would probably lean against heading towards surgery. The options would be, in my mind, upfront chemoradiation, or occasionally I think there are times that one can think about induction chemotherapy. There's no harm, no worsening benefit by proceeding that way and seeing how things go. I do think that certainly there are some patients that appreciate that opportunity to show themselves to do better than expected. And occasionally you'll see a nice response, and that will open the door for possible surgery. As you know, most of the trials comparing the addition of surgery have not shown a benefit in the overall population, so you have to be careful.
Dr. Julie Brahmer from the Sidney Kimmel Cancer Center at Johns Hopkins University in Baltimore, Maryland.
So we use actually lymph node size if the mediastinal lymph nodes are extremely bulky, so larger than 2 centimeters in size, then we actually won't recommend surgery at any point and do just stick with the chemotherapy and radiation as standard of care, which really is standard of care. For those patients with lymph nodes that are smaller than that or even microscopic, found at the time of mediastinoscopy, I think we'll tend towards using chemotherapy and radiation in the neoadjuvant setting, but also an equal option would be chemotherapy by itself before considering surgery as well. And a lot of times we'll use whether or not a patient's tumor would require them to undergo a pneumonectomy, then we would lean not to do radiation because of the high chance of postoperative complications. And then if the patient would just need a lobectomy, we'll do chemotherapy and radiation.
What chemotherapy most typically?
It depends. We usually try to use some cisplatinum-based regimen because we want a really good response. And depending on the tumor subtype will depend on what we use in combination with that. If we combine it with radiation therapy, we'll use the standard regimen of cisplatin and etoposide that was used in the large trial looking at neoadjuvant chemotherapy and radiation. And again, I think the cisplatin regimens will give you the best response with radiation.
Dr. Heather Wakelee from Stanford University Cancer Center in Palo Alto, California.
So with only 2 stations, not bulky, we would definitely consider a surgical approach. We would consider neoadjuvant treatment, and then we would have a big debate because we haven't reached a group consensus yet. In the old days, we would always give chemoradiation, and that's still what I would favor because I think that by adding in both modalities, you're much more likely to get your mediastinal nodes treated up front, which we know is the most important component of the neoadjuvant treatment, is clearing those mediastinal nodes. And chemo alone can, but is much less likely to do that than both. It's a shame that the intergroup trial that you were participating in didn't complete accrual, trying to answer the question of chemo versus chemorads. I would have been on the chemorads camp. However, my newer surgeons are less happy operating in a post-radiated lung, and so they will often argue against giving any neoadjuvant radiation. 2 of the surgeons are fine with it, and 2 of them aren't, and so it depends on whose day it is in tumor board and how concerned we are about the extent of mediastinal involvement as to whether they get chemo or chemorads.
Dr. Karen Reckamp from the City of Hope Cancer Center in Duarte, California.
This is where we collaborate incredibly closely with our surgeons and our radiation therapists and have our multidisciplinary conference. Most of these cases should be presented at a multidisciplinary conference where there's input from all the fields, because you really need to see the location and have the surgeons weigh in about really how resectable this is. And I have to rely on our surgeons to give me that information. And there's no substitute for being in the room and having that conversation and looking at together, because all N2 positive disease is not the same. And so it sounds like from this kind of case, I would anticipate our surgeons would say this is potentially resectable. And once they say this is potentially resectable, we generally give neoadjuvant therapy, whether it's chemotherapy and radiation or chemotherapy alone. For squamous cell, it probably would be more likely chemotherapy and radiation, especially considering the size of the primary. I would say most of these cases where it's smaller N2 disease, our surgeons would give them the benefit of the doubt and we would move forward with neoadjuvant therapy.
Are there situations in which you might foresee that the surgeon says, well, we could do surgery, but you wonder whether it is the best approach?
So that happens quite often, and that's usually when it's more bulky N2 disease, where I don't believe that any amount of chemotherapy and radiation is really going to eradicate that disease. then those are lengthier discussions. If the surgeon is fairly convinced that they have a chance, we generally go with the surgeon and give neoadjuvant, but we try to advocate for definitive concurrent chemoradiation for those patients who have bulky N2 disease, truly bulky N2 disease.
We hope that the program was helpful, and we'd again like to thank the folks from Longevity Foundation for their partnership on this program. Thank you.